and examples from eClinicalWorks, which is one of the systems that we implement in MedAllies. Okay, so core demographics. This is an example of one of the objectives, is record patient demographics that includes sex, race, ethnicity, date of birth, and preferred language, and then more than 50% of all unique patients by the eligible provider have demographics recorded as structured data, meaning that it can be reported on. So the way we set it up in eClinicalWorks is that the front office staff needs to collect this information, and we need some fields that are mandatory. So this is the eClinicalWorks registration screen, and as you see, we've made date of birth required, sex required, and then when they click on the additional info tab, the 3 additional fields, race, ethnicity, and language, are now required, and the drop-in boxes appear. So that's an example of one measure and how you would achieve it in an electronic health record. Another one is recording vitals, height, weight, blood pressure, calculate the BMI, plot the growth charts for children. You want more than 50% of all unique patients aged 2 and over seen by the eligible provider. The height, weight, and blood pressure recorded as structured data. In this case, the most appropriate person to do that is usually the nurse collecting the vitals. In our system setup, we have to map vitals, set them as mandatory, and carry forward the height any patient over 21. In the electronic health record, this is an example of eClinicalWorks. They have this grid. These are mandatory fields now where they enter the height, weight. It will calculate the BMI, blood pressure, and for the children, they can click on the growth charts.
Another question?
Sure.
Adults, you have to keep recording height?
In this system setup, we've had the height carried forward after the age of 21 as part of the system setup.
Okay.
So if the electronic system can do it, you're set. If it can't, you will have to record it. I feel like Susan going super fast there. Okay, computerized physician order entry of medications. You need more than 30% of unique patients with at least one medication in their medication list seen by the eligible provider have at least one medication order entered as CPOE. So you are prescribing electronically in the system. In this case, the actor is the physician who is usually prescribing the medication. Part of MedAllies training in order set creation training stage 1 is the class that we teach how to set this up. I'll show you what it looks like. So in this particular EHR, we have things called order sets, which are quick ways to list medications, to list the labs typically order, the diagnostic imaging, the procedures, immunizations, and future appointments. So in the system, a physician can meet this by prescribing the medication, which these 2 buttons right here. They want a follow-up done on this patient, and then basically they click the order button. That will shoot those prescriptions over to the pharmacy electronically for the patient to pick up. It will also schedule, send a notification to the front office staff that this patient needs follow-up. Electronic prescribing. In electronic prescribing, the way we set it up is the front office staff is responsible for collecting the preferred pharmacy for the patient. You want to do that at check-in. They usually ask, where would you like your medications to go to? Both mail order and retail, and then more than 40% of all the permissible prescriptions written by the EP are transmitted electronically. So in the application for the physicians, they would click E-Prescribe. The electronic prescribing screen would come up. They would confirm that they want this medication, and they would send it electronically. Drug-drug and drug allergy interactions. The one we like about this one is it takes no effort. It just needs to be set up in the system to be enabled, the drug interaction check. So we call it a freebie. You get a freebie, you don't have to do anything. You can satisfy a measure. All you have to do is make sure this is enabled with your vendor. In eClinicalWorks, we know it's enabled because the interactions come up when the 2 medications are trying to be prescribed together. Core clinical visit summary, another objective. For every patient that comes into the practice, you are providing more than 50% of the time a clinical visit summary. This is one of the hardest measures to achieve with our practices because it's a change in workflow. The after is the front office staff or the physician can print this out. So your check-in, check-out, or your doctor, depending on the workflow in your practice. You have to set up visit summary defaults in your print option, which I'll show you the screen for an EHR. And it must be done individually in this particular application by user. So each user has to have this set up. This is only printing out certain sections of this SOAP note. I'll show you what it looks like. In this system, there is a function called print visit summary. At the end of the visit, the office staff, the physician, clicks this button. The system's going to ask you can set these as default. Medications, so anything you prescribe, any tests you order, any referrals that you've sent out, when their next appointment is, any health recommendations, their diagnosis, any immunizations you've given, and any preventative medicine guidance appears on that summary. You can uncheck some of these. You can just have a default that they're automatically checked, and then you do print. Now, providing the clinical summary is a mandatory objective in the core set. So this is, the numerator is the number of patients in the denominator who are provided a clinical summary of their visit within 3 business days. We want to set it up a couple different ways because this can require a lot of printing of paper. For this particular application, there is an option to set up a patient portal where those patients can receive the visit summaries electronically. You have to give it to the patient within 3 business days. So if the patient is leaving the practice, now you have mailing cost. So that's why we have the workflow when the patient leaves the office to provide the clinical visit summary. It's based on the patients in your EHR. So you can use all the patients, but the EHR is going to calculate by what you've done in that print button. So don't create extra work by creating a document to print and hand to the patient. It will be done in the system. For this and percentage-based calculations, we encourage practices to aim for 100% on this, and the EHR objective is only 50%. We strongly believe that in stage 2, the optional measures and the 5 out of 10 will go to 10 out of 10 in stage 2. So if you're going to make workflow changes in your practice, it's easier just to aim for the 100% now than to go back and try to redo the workflow or add the additional workflow in stage 2.
Can you, sure. So for this, so this is a core measure, so we must meet this 50% of our office visits.
During that reporting period.
Right, so what you're saying is at the end of the patient visit, before they leave, we print a summary and
hand it to the patient.
Well, print a summary.
Yes, print a summary. I can tell you as a patient in any clinical work practice, it is actually great. It summarizes my visit, when I'm supposed to be back, what test I'm going to get. So it's also good PR for the practices because the patients really like having that summary and their medications are on there. And if they can keep that medical summary, if they're going to another provider, it's easy to hand that to a provider and say, this is what I got done in my last visit with my primary care, and hand that to a specialty physician.
Going back, how does CPOE prescribing medications differ from E-Prescribing?
Okay, so you can send a prescription via fax to a pharmacy where when you're prescribing, you hit that fax button, it goes to the fax machine just like you're sending a regular fax. CPOE entry of a system is the electronic connection to the pharmacy information system. So in this country, most of what we send is through SureScripts. Are you familiar with SureScripts? Which is like a big pharmacy hub. So it connects the mail orders, it connects the retail pharmacies through this big SureScripts hub. All the EHR vendors have a connection to SureScripts, so they are transmitting it electronically. It goes into the pharmacy information system directly into the computer. So it's CVS, it pops up in the inbox, and actually I was fortunate to get the tour of CVS and how that works on the CVS end and go behind the scenes of the pharmacy with one of our local pharmacies because the pharmacists were claiming that they never received it. But it is all tracked. They can receive it, and if there's an issue, SureScripts will investigate it with the pharmacy and say, no, this was confirmed from your information system and acknowledgement received. It is tricky if you've done electronic health records. Luckily in this region, because of the high adoption rate, a lot of pharmacies are on electronic. But when we started this, 7 years ago, it was like pulling teeth to get pharmacies to understand. Patient would come in and say, I have a script. They emailed the script, and the pharmacy would normally say, we don't accept emails. And then they would call the practice back and say, we don't have it. I think that's evolved a lot in these counties, especially with the groups that have adopted. It kind of paved the way for you guys to get pharmacies compliant, so it's rare that I have a non-compliant pharmacy that will do that.
But if you do an e-prescription, does it also give you credit towards the CPOE measure?
In some practices, there are staff that actually control prescriptions, but that doesn't come the same way as the physician sitting as the patient and transmitting it, or is it the
Whoever's
same?
allowed to send that prescription electronically in the practice, and that would be per practice policy. So if you have somebody that's saying, okay, a nurse is allowed to send this medication, and she's allowed to send it to the pharmacy, that would be, it's just calculating that patient's med sent electronically to the pharmacy. And patient meds.
Just so I'm straight, the clinical visit summary is going to be printed up at the end of the patient's visit and handed to the patient.
Yep.
All right, now what about if you have an office where multiple languages are spoken by the patient? And some patients we're an office where there's a lot of indigent patients there that don't even read or write. They sign their name with an X. How is that going to help?
Well, the regulation is to print it, and they didn't.
And it doesn't go anywhere. It doesn't mean anything.
Right, it doesn't mean anything to the patient.
It's just for paper.
Or if they, English is not their primary language, but the requirements for the print
I
button.
guess they didn't take that into consideration.
Well, and just one quick comment. We've been working with the health center on this issue, and one of the things that a health center with a strong indigent population, non-English speaking, one of the things they've been saying to the patient is, keep this, share it with a family member who's involved with your care, or if you go to see another doctor, take it with you. I know it's not perfect, I completely get it, but that is the strategy that they've been saying.
I have a question about that.
It doesn't show helping the patient, it just shows that you can.
The vendor that I happen to be using at this point in time did state to us, because we're on this topic, that if a patient doesn't want it, you do not have to print it, you just have to sign it. But there's no mandatory law that says you have to print these and give them out if the patient doesn't want it. You just be wasting paper.
Correct, but you have to trigger whatever the
Trigger it.
mechanism behind the scenes in the EHR is to print it and calculate that total. So in eClinicalWorks, it's the print button. And I understand that you can print and then cancel the print right now in the system. So it's really, it's the technology that you have behind the scenes.
Right.
But there's no regulation that says in it, I mean, you should hand it to the patient and give them a copy, and they say, I don't want a copy, that's fine.
Okay.
Okay, so there are, just some technical additional information. So the providers are permitted but not required to limit the measure of the objective to those patients whose records are only maintained in an EHR. So they are not calculating if you're in the middle of a transition to a paper chart, the paper chart's in there. The provision of the clinical summaries is limited to the information that's contained within the EHR technology, meaning that that information exists already, your problem list, your medications, your allergies. If the eligible provider believes that substantial harm may arise from the disclosure of information, so you have a patient that maybe has some mental health illness along with their regular medical problems, you can choose to withhold that information from the patient, and providers are not allowed to charge the patient a fee to provide the information. Okay, I'm going to go quickly through a clinical quality measure, and this is the hypertension blood pressure management clinical measure. So how they're calculating is that for patients who are age 18 and older and they have a diagnosis of hypertension, who have been seen for at least 2 office visits with a blood pressure recorded. The way they calculate that, you'll recognize either the hypertension and ICD-9 codes. If they appear in the EHR and the patients are 18 years or older and they have 2 face-to-face encounters in the reporting period, the patients must have at least 1 blood pressure recorded in their chart in the vital signs. Here's an example. Patient in eClinicalWorks has a problem list. Hypertension appears. They're over 18. The way we've set it up in the system is that when the vitals are entered, we've created those to be mandatory. They are yellow. The blood pressure is entered from 20/80, and you satisfy the measure. Do you want me to keep going with examples? This is good? Okay. This is the adult weight screening. The follow-up measure definition is percentage of patients who are 18 and older with a calculated BMI in the past 6 months or during the current visit documented in the medical record. And if the BMI is outside parameters, a follow-up plan must be documented. Here's an example of meeting this type of measure. We've calculated the height, weight. The system has calculated the BMI and the weight chart difference. So what we've done is we've created in the templates a way to document that the meaningful use adult weight follow-up and assessment, or if it's a child, we've put in there a standard template that providers can use to meet this measure. Makes it a little bit easier. So we would select the adult weight follow-up assessment, and what would appear in the note would be the dietary surveillance and counseling code, and then the way we worded it is BMI management. Patient was counseled on a weight management program. I specifically reviewed the patient today, attaining a healthy weight, following exercise regimen, appropriate for the patient, and patient-specific counseling was provided on diet and nutrition. So that's whether the patient is overweight or underweight, satisfies the measures because I've documented follow-up plans. So MedAllies, we have a chief medical officer who has worked probably for about 5 months on how to take the electronic health record and meet each of the core measures and who is the appropriate person to do that actor role in a practice. We developed a guide for our end users and our practices to actually step by step